Respected Chairperson and my dear friends, I am going to speak on SMBG for all diabetics is not very important, and I am going to prove it. There is no disagreement on the utility of SMBG in type 1 diabetes and type 2 diabetes on insulin therapy. However, there is conflicting evidence on the clinical benefits of SMBG for the type 2 diabetic patients who are not on insulin therapy. A nocebo or negative effect is also described by a few studies which shows that SMBG in non-insulin treated diabetic patients results in increased anxiety and depression. So, is self-monitoring of blood glucose appropriate for all type 2 diabetic? The pre-mental diabetes Australian study showed that both cross-sectional and longitudinal data showed that HbA1c was not significantly different between SMBG users and non-users, either overall or with diabetes treatment group on diet, OHA or insulin with or without OHA. There was also no independent cross-sectional relationship between HbA1c and SMBG frequency. Then I went into Cochrane review. So what does the Cochrane review say in non-insulin treated type 2 diabetic patients? Recent systemic analysis, review and meta-analysis of 9 randomized controlled trials, including 2,324 patients investigating effects of SMBG published since 1989 in newly diagnosed or stabilized type 2 diabetic patients for more than 1 year. What the study shows, in stabilized type 2 diabetics, pooled analysis results in a minus 0.26 decrease in HbA1c after 6 months. This decrease did not meet the generally agreed clinical relevant level of even 0.5%. And even after 12 months of follow-up, it also lacks statistical significance minus 0.3, as evident from the DIGEM and the Zodiac 17 trial. And also there were no significant differences between the groups who self-monitored their blood glucose and control groups in patients-oriented outcomes such as health-related quality of life, overall well-being, and patient satisfaction. Only 2 studies, examples the San Carlos studies on patients with newly diagnosed diabetes, comparing SMBG versus usual care, showed a statistically significant decrease of 0.5% in A1C measurements at 12 months in the self-monitoring group. However, there were differences in education on lifestyle modifications and drug interventions between the groups, made it clear whether SMBG was actually responsible for the observed effects. Then, the PRISMA study, prospective randomized trial on intensive SMBG measurement, showed that in a non-insulin treated type 2 diabetic patient, SMBG is only useful when the glucose data are collected in a structured manner, accurately interpreted, and utilized to take appropriate therapeutic action. Only keeping the data and not utilizing it for action won't help. And the Trinidad study we showed that impact of SMBG on metabolic control in patients with type 2 diabetes. In patients with diabetes on insulin can obtain a quick and accurate reading of the blood glucose level and can titrate. But patients with type 2, how many patients with type 2 diabetes on OHA titrate their dose? So the study showed no direct benefits of SMBG to this group of patients. My friend Anuj was talking about hypoglycemia and SMBG. There is a low level of evidence in the type 1 diabetes and type 2 diabetes using insulin of benefit of SMBG on HbA1c and hypoglycemia. But there is a high level of evidence that there is no clinical relevant effect in lowering HbA1c in type 2 diabetes not using insulin, and there is moderate level of evidence showing that there is no benefit evidence effect in identifying hypoglycemic events. Then the Leventhal common sense model, what it does is suggest diabetic self-care activities, SMBG may have a beneficial effect on lifestyle behavior. It is true, SMBG would potentially improve self-care attitudes, control beliefs, motivational behavior, leading to positive changes in well-being and quality of life. But evidences are saying something else. Randomized control trial investigating the effect of SMBG on quality of life are not available. DCCT trial in diabetic patients on insulin, impact of SMBG on quality of life or well-being are hard to find. Results from observation and qualitative studies suggest that SMBG might negatively affect quality of life. Studies exploring general well-being and quality of life in non-insulin type 2 diabetes could not reveal any evidence of a positive or negative effect. So, the question comes in mind, is SMBG cost effective? SMBG non-insulin type 2 diabetic patients is a waste of money according to Davidson, and different studies have shown from Canada, the UK, the Netherlands, that millions of dollars are spent and the cost effective ratio was not meaningful. So there are other limitations of SMBG also. Calibration and accuracy of glucometer is very important limitation of SMBG and has to be standardized. SMBG cannot predict the future trends of blood glucose, cannot predict the glycemic variability, which is more predictable by using continuous glucose monitoring system. Strips should be stored at the correct temperature. Repeated lancet injuries are a major cause of poor compliance and non-adherence. Concerns of contamination and possible spread of bloodborne pathogens like hepatitis are also there. Then there is no consensus on how many test strips should I prescribe or how frequently should my patient test their blood glucose. Remember, data for ideal frequency of SMBG in insulin requiring patients are lacking. The current frequency needs to be individualized based on diabetes, type, A1C target, frequency, risk of severe hypoglycemia, and cost. Also, the ADA guidelines suggest that SMBG may be useful, not useful, but may be useful in selected patients using less frequent insulin injection or non-insulin therapies, and recommend that those patients receive educations on how to use the self-monitoring data to adjust their therapy. Level of evidence E. Then what the other guidelines suggest, NICE guidelines suggest routine SMBG in people with type 2 diabetes not on insulin is not recommended. It is recommended with type 1 or type 2 diabetes who are using insulin, where patients are educated to appropriate alterate their insulin dose, and it should be available in the patients of type 2 diabetes who are starting secretagogues for the first 3 months, or in the drivers to adjust their dose, because the fear of hypoglycemia is early in the first 2 or 3 months, but not later on. Then what do IDF says? IDF says SMBG should only be used when the patient has the knowledge and willingness to incorporate SMBG and therapy adjustment into their diabetes care plan in order to attain agreed treatment goals. Scottish Intercollegiate Guidelines Network is in accordance with the NICE guidelines. So to conclude, SMBG is not very useful in all diabetics. It is evident that implementing SMBG in unstructured ways without training patients and clinicians is likely to be a waste of resources. This money can be utilized to use of newer glucose lowering therapies like new costlier insulin or gliptins and structured education program. Indeed, the focus on glycemic control alone is not appropriate in people with type 2 diabetes, and a more holistic approach, including blood pressure and lipid management to reduce cardiovascular risk, is more beneficial. And encouraging very tight glycemic control, A1C less than 7% may be harmful, as evident from VADT, ACCORD and ADOPT studies, especially in those with long-standing diabetes of more than 8 years or in the elderly. Thank you for your patient hearing.
Thank you.